We're good to go.
Okay. A warm good evening, everyone. I'm Dr. Sravani, Consultant Emergency Medicine, working at Yashoda Hospital, Secunderabad branch. Every Friday, we Yashoda Hospital come with few interesting topics to create the awareness and increase the knowledge among the participants. Yet today, we have another interesting topic that is management of diabetic ketoacidosis. To deliver the talk, we have Dr. L.D.V. Prasad, who is a consultant emergency physician working at Yashoda Hospital, Hitec City. Welcome, Dr. Prasad.
Thank you, Dr. Sravani.
Okay, so let's start the session. Over to you, Dr. Prasad.
Thank you. Thank you for the kind introduction. So I'm Dr. Prasad. So I welcome you all once again to our Friday webinar series. So today we have yet another interesting topic, and which is very commonly seen, and which is a vital emergency to handle by an ER physician. So that is diabetic ketoacidosis. So we all know it is called as DKA. So basically DKA itself is DKA is a preventable disease. So it's very commonly occurring in a society, and it is most commonly life-threatening if left untreated. So it's very much common in type 1 diabetes, but although its frequency is seen in type 2 as well. So unfortunately, the reason we have brought this topic is, although it is very commonly seen and very frequently occurring in our society, so it is frequently being mismanaged. So since the last decade, if you have seen, there is a significant way of presentations, change in presentation of the patients. So for instance, we'll be saying, in these days, we see patients with normal glycemia. We don't usually see you call it as euglycemic DKA. Normally, you don't see patients with, in the past, 1 decade ago, basically we used to think DKA is when patient has high sugars and some symptoms, we used to think about DKA. But for now, the trend of the disease has changed. So the patient is having DKA despite having normal blood sugars. So that is one thing. So very important thing. The one more trend changing. This is in pertaining to the clinical presentation. In pertaining to the diagnostic testing, basically the point care testing has changed the entire dynamics of the DKA management. So this point care testing can be done just like you do a blood glucose. You can also test the ketones at the bedside itself. So the ketone that you're testing is beta hydroxybutyrate. So just like a glucose, how you do an hourly ketone body assessment at bedside itself. And as we know, the ketone bodies are acetone, beta hydroxybutyrate, and acetoacetate. So the mortality has significantly fallen in last 20 years because it is being properly managed, and we have a specific diabetic specialists which are available with us and who are managing things better. However, the mismanagement is also very much common these days. So how do we address this situation now? So we address this situation by early diagnosis and implementing early diagnosis techniques, and then implementing an effective prevention programs by community education. That will come later. So recently, in past, we used to treat majority, if someone says DKA, everybody's focus used to be on glucose in the past. But now the entire equilibrium has been shifted to ketonemia. So we are addressing more of ketonemia rather than blood glucose. So we'll be coming through all these slides in one by one, but it's just a brief introduction about the topic. And then there has been a recent meta-analysis which showed that comparison of urine ketones versus blood ketones, which showed when you're using a blood ketone as a measure to measure for a diagnosis, then it shortens the length of the stay, and it also enhances the recovery faster. So, and then coming to the resolution of DKA, basically it depends upon suppression of the ketonemia. There is a measurement of blood glucose now, which is the best practice guidelines in response to the treatment. So in the real time itself, we can do. Actually, till now, because even now, we don't have a capillary blood ketones very much available in any majority of the organizations. So we still rely on the urine ketones to make a diagnosis. Although to make a diagnosis, you don't need a urine ketones. That will come because the urine ketones will not be detected in the initial phases of DKA. In the similar way, DKA, after the resolution of the DKA, still you can still see the urine ketones being positive. So urine ketones, using urine ketones as a surrogate marker for treatment is obsolete now. So now, since the topic is diabetic ketoacidosis, first we'll discuss about the glucose metabolism. So the glucose metabolism, so the glucose is metabolized into phosphoenol pyruvate and then pyruvate to the lactate, which is a reversible reaction. It can happen in bidirectional way. So generally, with the help of insulin, your muscle makes up the pyruvate and lactate, and the lactate is taken to the liver and it is again formed into the glucose by gluconeogenesis pathway. So now coming to our core topic, what happens with the DKA? So DKA, either you have an absolute insulin deficiency or you have insulin resistance. So what happens as a consequence of it? Your functions of your insulins are impaired. So very important function of insulin is to inhibit hormone-sensitive lipase activation. So when there is a deficiency of insulin, this hormone-sensitive lipase get activated. So what it does is, it acts on the adipose tissue and it mobilizes the free fatty acids from the fat adipose tissue. And it also releases prostaglandins, which is a common cause for having nausea and vomiting and abdominal pain secondary to DKA. This is one of the clinical manifestations that you see. So as we all know, there are counter-regulatory hormones. We have a backup mechanism for everything in our body. So once the insulin deficiency is there or resistance is there, so counter-regulatory hormones will come into the picture. So what are those counter-regulatory hormones? Counter-regulatory hormones are glucagon, cortisol, growth hormone, and catecholamines. What does these do? So when these come into picture, they break down the glycogen. So they call it a glycogenolysis happens in liver and the muscle. So, and also there is a ketogenesis. This is a core concept of DKA. So when there is deficient insulin, you have a hormone-sensitive lipase getting activated, which shift the entire metabolism towards ketogenesis. And as a result, you will have you have a ketone body generation. So now, what happens in our blood now? So ketone bodies are being secreted. Ketone bodies are ketoanions. We call them as ketoanions. So they are more acidic. So they stimulate your respiratory center. And since you have a high sugar, so you causes osmosis. So or you make your blood very much thin. Okay, you have something called hyperglycemia. Hyperglycemia will cause osmotic diuresis, which further decreases the volume depletion and electrolyte loss. So this is the same representation. So basically, when there is a deficiency secondary to usually type 1 diabetic patients or type 2, anybody who has a stress or infection or insufficient insulin intake. So you have increased lipolysis and then decreased glucose utilization and increased protein breakdown. So as a consequence of all this, you will decrease as the ketoanions. As I already told you, these ketone bodies are ketoanions. So they increase the acid levels, thereby your buffering system. What is your buffering system? The bicarbonates try to neutralize it, but your bicarbonates are consumed. So thereby your bicarbonates drop, thereby your pH also drops. So coming to the lactic acidosis, majority of you ask, what is the importance of lactate? So importance of lactate is, as we already discussed, when you have a glycogenolysis, so the end product is pyruvate. So the pyruvate would change into the lactate depending upon the what type of metabolism you have. You have aerobic metabolism, you have anaerobic metabolism, what factors are determining the metabolism. So this is about the basics biochemistry of the DKA. So coming to the core topic now. So as we split DKA, so D is for diabetic. So DKA can happen in any diabetic patients, or if blood glucose levels is more than 11 millimoles per liter. If you're not using millimoles per liter, we can convert millimoles per liter into 1 millimole per liter into 18. You can get your mg per deciliter, which is commonly used in our settings. So then potassium, then the ketones. So ketones, either you do a capillary or blood ketones. If your ketones are more than 3 millimoles per liter, or if you're not working in a setup where you have a ketones, then blood ketones you can do. So if you cannot, you have to do a urine dipstick test where you should find moderate urine. So the moderate ketonuria should be there. It means more than 2+. So, and coming to A is acidosis. When do you call a DKA? When you call acidosis, when pH falls less than 7.3 and bicarbonates fall less than 15. So this is a classification of DKA. This is basically, if you break down the DKA, these are the components of DKA. So now coming to the causes, what are the most common cause of DKA? So I remember it as 4 I's. One is infection, infarction, any infection. It could be a pneumonia. Most commonly, it would be pneumonia or UTIs usually. And for that matter, any infection can cause DKA because the infection increases the stress response. As the stress response increases, your counter-regulatory hormones increase. And we have already seen what is a down running of the counter-regulatory response. And then you see an infarction. So infarction is also one of the components. You see, most of the times you get MI patients and stroke patients having high sugars. So it goes both ways. And the high sugar can cause stroke and MI, or the stroke and MI would have triggered the DKA. So it goes in both ways. So intercurrent illness. For example, if you have some medical problem or fever or something which is making you ill, then probably that could also cause DKA. So one more majority of the cause is insufficient insulin. So most of the times, we know that, especially if you're talking in terms of type 1 diabetes, non-compliance is one of the major factor which adds to their mortality. So because they miss their dose or they're exhausted with the compliance of the insulin administration. So because of insufficient insulin, again, your pathway shifts towards ketogenesis. And these days, SGLT2 inhibitors are very widely used because they are nephro and cardioprotective. So irrespective of you have a DKA or not, or you have sugars or not, these drugs are tried in heart failure treatment as well. So basically, SGLT2 inhibitors are very widely used. And even in diabetic patients, SGLT2 inhibitors decrease the mortality from the kidney and as well as heart side. Basically, they are both renal and cardioprotective. So now, what is the basic treatment that you give in a DKA? So first is you assess clinically. What is the clinical presentation the patient presents to you with? Is the most common clinical presentation is patients come with abdominal pain, vomiting, or fever. And biochemical assessment you do is, as soon as you see, because capillary blood glucose is one of the vitals that you check in the ER. So as soon as you identify the blood sugars are high and you find any of the clinical signs suggestive of acidosis, something like rapid breathing or rapid breathing that you can easily identify, and you find chest is very much clear, because this breathing is not because of pulmonary edema or anything. It is breathing is secondary to because the respiratory center is being stimulated by the acid. So your chest would be obviously clear. So the next important step is commencement of normal saline. Fluid is the mainstay of the treatment in diabetes, diabetic ketoacidosis, and commencement of fixed rate insulin infusion rate. And then early referral to HDU in severe DKA. Severe DKA is when pH falls less than 7 and bicarb is less than 5. So a referral to diabetic team should be given. So total deficits. What do you have? What deficits do you have in DKA? So in an adult, on an average, you will have a deficit of water of 100 ml per kg. If you were to diagnose a patient with DKA, this patient will have this kind of deficit in his body. So that's the reason. See, if you can see 100 ml per kg is a very huge volume. So the primary role is to correct volume. And you have a sodium correction, 7 to 10 millimoles per kg. And chloride is also decreasing. Potassium will vary depending upon the severity of the potassium depletion or as a consequence of the treatment. It goes in both the directions. And phosphate also will be reduced. So now coming to the sodium. So there is something called pseudo hyponatremia. So when you find a sodium is abnormal, you will have to correct the calculated sodium. So the calculated sodium is, for instance, if you have a if you have a sodium of 500, then anything above 100 is 400, right? So anything above 100 is 400. So you multiply 4 into 1.6. So you get the corrected calcium. So anything above the 100, whatever is your GRBS, multiply that into 1.6. You get the corrected sodium. So now, we have made a diagnosis. Now you have a patient who has come with abdominal pain. Now his sugars are high. You have a rapid breathing. You have abdominal pain, nausea, vomiting. He looks significantly dehydrated. So now you have already done a VBG. VBG is showing 7.3 pH, bicarb of 14. And if you have a blood ketones would be positive. So you have made a diagnosis of DKA. Now, what is your role now? As an emergency physician, what is your role? So your role is to commence 0.9% sodium chloride solution. As we already discussed, it is because the osmotic diuresis, volume depletion secondary to extravascular volume loss, and then there is a deficit. So we have to correct all these with the saline. And then once you commence the saline, and then what is the next treatment? It is intravenous insulin infusion. So what is the infusion that you give is human actropate. It is a regular insulin, 0.1 unit per kg per hour is what we usually give. And then if the patient normally takes long-acting insulin, you should ask them to continue that insulin. Do not stop the long-acting insulin. And what would the next step would be? Check vitals and full clinical examination. The action 4 would be further investigation depending upon need for clinical contacts, whatever you want. If you're suspecting some infection, then you can send blood cultures. If you're suspecting a pneumonia, you can ask for a chest X-ray, so on. And then the very important part is, see, we have already started fluid and insulin. So important part is step 5 in DKA. So the step 5 is establish a monitoring regimen. That is a very vital part in DKA management. So hourly sugars should be checked. Hourly capillary ketones should be checked if available. Otherwise, if not, venous bicarbonate and potassium should be checked at 1 hour. And then thereafter, it should be checked every second hourly. And electrolytes should be sent 4th hourly, and there should be a continuous cardiac monitoring. Why? Because the electrolytes. See, DKA is not just a sugar disease. I've been keeping on telling the same thing. It's more of the ketogenesis that we are more concerned about. And as a consequence of treating this DKA, you give insulin, so which will definitely have an impact on potassium. So it can be a hypokalemia or hyperkalemia. So you will have, in either of the conditions, you will have electrical instability. So we recommend cardiac monitoring for every patient whom we are treating as a DKA. And always consider the precipitating cause and treat the cause simultaneously along with the above treatment. So now coming to the fluid choice. So as I've been constantly stating, so the fluid is the first treatment of choice. So now, what is the choice of the fluid? There have been so many randomized control trials which have been performed, and there is none of these study has shown any significant superiority of one fluid over the other. For instance, like balanced solution like plasmolite versus sodium chloride was tried in many studies, but there is no statistically significant improvement with any other choice of the fluid apart from 0.9% NS. So at the moment, as per the evidence we have, at the moment, the choice of fluid is 0.9% sodium chloride. So how should we give? As we all know, we'll just have, books will have a general statement that we'll have to give 1 liter over 1 hour, and then 0.9 NS 1 liter with potassium chloride over next 2 hours is what we are recommending. So, but in real context, what we have to do is we don't go by hard and fast like this. So we'll have to assess the clinical context. So here we'll have to see if my patient is grossly dehydrated, is having decreased capillary refill, is having signs of shock, or is there anything that is pointing towards more of shock and gross dehydration. If that is the case, and there are no complications, if this is the case, then you can give 1 liter of fluid over first hour. But if there are any confounding factors, like the patient is already in fluid overload, a patient is a CKD patient or heart failure patient, then you'll have to give a cautious fluid administration. The point I wanted to make in this slide is, so the choice of the fluid is still 0.9% saline, and the rate of fluid infusion is dependent upon the clinical context. It is not just that the book says give 1000 ml per 1 hour, please don't give like that. So you have to correlate, you have to use your clinical acumen in judging how much fluid should be given and at what rate should be given. What are the parameters that you should monitor? So if patient is in shock, what are the normal things that you see when you're giving hydration to a patient? One is urine output. The other one is decreasing heart rate. If there is a hypotension, improving blood pressures, then improving respiratory rate, improving capillary refill time, improving skin turgor. These are all the things that you should assess in any patient. And coming to the common, because we're all ER physicians, we use focus left and right in our emergencies. So you should also bear in mind, because the patient is severely dehydrated, obviously you're going to have a kissing IVC in majority of the cases. And IVC cannot be relied in certain situations. Please bear those conditions in your mind and go ahead. So we cannot call, and most of the times it is not just the IVC collapsibility index. We should always look at the collapsibility index in a patient who is coming to the ER and has a spontaneous breathing. If the spontaneously index indicates, then you will have to dictate your fluid accordingly. If the patient is intubated, then usually we don't intubate because these patients usually respond well with the medications. But if you had to intubate for some reason, so you have to use distensibility index in guiding the fluid. So the guidance of the fluid is determined by multiple factors. So please bear those things in the mind. Monitor urine output, good vital, and then proceed with further fluid administration. Next. So the only insulin which can be given is, so we all know that we have different forms of insulin. We have ultra short acting, long acting, intermediate acting. We have all this kind of insulin, but only the regular insulin, human ectrapid, is our only insulin which is available in the IV form, and you use this. Why do you use this? You have a shorter half-life and it is easy to titrate. So insulin therapy, as we already discussed, it is 0.1 unit per kg per body weight is recommended dose. Why do we give insulin? That is the most important part. So here we are not addressing the glucose. The glucose-centric approach should be forgotten. So the predominant role for us is to suppress ketogenesis, because that is a prime centric pathogenesis in DKA. So suppression of ketogenesis is only our aim. Then reduction of blood glucose, obviously insulin is going to push is going to stimulate your insulin sensitive regions like muscle and all to take up the glucose. So there'll be reduction in glucose. and correction of electrolyte imbalance. As we already discussed, the most important electrolyte which should never be forgotten is potassium. So potassium disturbances, potassium, either it can be hypo or hyper. So you have to adjust your titrate, your treatment accordingly. So the maximum rate of insulin infusion that you can start is 15 units per hour is the maximum that you can go. So minimal is, if patient is my ideal body weight is 70, then you'll go at 7 units per kg per hour. 7 units per hour, sorry. So now, so before you go, we do an VPG. So we don't usually get a ready-made potassium, lab potassium all the time. So we do any VBG. I think in a majority of the centers, VBG correlates well with the potassium. So if it is the situation, then you can be guided by the VBG's potassium. If initial potassium when you're starting a fluid or when you made a diagnosis is more than 5, you don't have to supplement any potassium. If the serum potassium is 4 to 5, supplement 20 milliequivalents. And the fluid that you supplement is dependent upon the volume status of the patient. And 3 to 4 milliequivalents, if potassium is 3 to 4, then you have to supplement 40 milliequivalents, again titrated to patient's volume status of the body. And then if your initial potassium is less than 3 on your initial diagnosis, then you should never give, you should hold the insulin infusion. First hydrate the patient, supplement potassium, and then give insulin infusion. Because insulin is going to push your potassium in, you're causing iatrogenic hypothermia, hypokalemia, which could be a deleterious effect on the heart muscle, can throw arrhythmias, and patient can have a sentinel event. Then, what are the, now we have seen the treatment part. So what is the choice of drug? Saline, we have seen. Insulin infusion, if your potassium is well above 3, you can still start insulin infusion. You have adequately hydrated and you're concurrently correcting your this thing. So this is what is the treatment and what is your target. So you have already started a treatment. So you should have some target in front of you so that you can modify your treatment. So your treatment target is reduction of blood ketones concentration by 0.5 millimoles per hour, and then increase in venous bicarbonate by more than 3 millimoles per hour, reduction in capillary glucose by 3 millimoles per hour, or maintenance of potassium between 4 to 4.5 is our target. If this target is not maintained, either you have to supplement it or you have to address it by, if it is hyperkalemia, you have to address it accordingly. If it is hypo, you will have to supplement potassium. If these targets are not met, so basically we have started fluid, we have started insulin infusion, but we have set our targets right in front of us, but these targets are not met, then what should you do? You should increase your infusion rate by 1 unit. This is according to the British diabetic societies. So different books give different, but at the moment, the literature that I'm speaking to you is taken from the British medical journals. So now we have achieved our targets. Now what should be our resolution? So when do you call it as resolve? So you call it resolve when patient is able to eat adequately and your anion gap is closed and all your targets are reached. Basically, when you reach these targets, then your pH should be more than 7.3, your bicarb should be more than 15, and then your anion gap should be closed. This is your target. And at the end, your patient should be able to eat. So now imagine we have treated a patient. Ideally, the DKA patients usually will resolve in 1 day, maximum in 1 day. Usually they come back to the metabolic, the metabolic derangements are usually corrected in 1 day. If not, there is some challenge with our treatment process. So that we'll have to troubleshoot. So now if my patient is eating, then I'll have to continue my insulin infusion and then give him subcutaneous insulin and then stop my insulin infusion. This is what is recommended. There's something called variable insulin infusion rate. If patient is not eating, but DK is resolved, pH is improved, bicarb has improved, anion gap has closed. Then in those cases, what you have to do is there is something called variable infusion rate, where you supplement some amount of glucose and titrate your target sugars according to your local guidelines. So if the patient is having a previously basal insulin, that should be continued as per the regimen. So now assessment of severity. So when do you call my DKS very severe? So when your blood ketones are over 6 millimoles per liter, bicarb is below 5, venous or arterial pH is less than 7, hypokalemia on admission, GCS less than 12, oxygen saturation less than 92, systolic blood pressure 90, below 90, and pulse rate over 100 or below 60, or anion gap more than 16. If you are using this formula, if you are eliminating potassium, it is different again. So now, what is that you will do? You have done whatever the treatment has to be initiated within 1 hour. You have already initiated 5-6 actions. Now it is time for you to dispose, because ER is a short stay department. Now we'll have to hand over our patient with the continuum of care to the other department. What would be the other department? ICU or HDU. So whom do you refer to ICU? Young people who are 18 to 25 or elderly, pregnant, heart failure or kidney failure, or severe comorbidities, in addition features of any DKA that we have already seen. So the complications are hypokalemia, hyperkalemia, and hypoglycemia, cerebral edema, which is not very much common in adult, but it's very common in children. And then what are the other complications that you see? Thromboembolic risk, because once your blood sugars are shooted up, so your blood becomes thick. So there is a high risk of thrombosis. And then pulmonary edema, because if you go overzealous vigorous fluid administration, then probably you'll have a pulmonary edema. Pancreatitis, because you, as we already discussed, DKA is more of a lipid disease. You have more lipolysis. So what happens? You increase your triglycerides. So the increased hypertriglyceridemia would cause acute pancreatitis. So now we have discussed the complications. The very important complication is hypoglycemia. So majority of us think, so hypoglycemia we have to address with supplementation of the glucose. But the other aspect that we should see is when you have a because you're giving insulin, obviously it's going to push your glucose inside. So now what you're going to do is when you have a hypoglycemia because of your insulin infusion, which is not very much monitored. That's why I said the action 5 is very important. You have to set your criteria of monitoring. So that is a very vital part. So if patient has hypoglycemia, what is that you're going to do? So what happens to your physiology? Now again, we go to the step 1. Your counter-regulatory hormones will come into the picture, and again, they will cause increased lipolysis. And this vicious cycle continues to go on. So if you're giving an insulin therapy, hypoglycemia is one thing. The other down part is you might have rebound ketosis if you have a hypoglycemia. So careful, watch out of the glucose level should be monitored. So at what level you will come into picture? That would be next question. So when your glucose level is falling less than 250, ideally you would ask the nursing staff to inform you about the patient. Then you will supplement 10% dextrose accordingly and continue the insulin infusion. So next common is a DKA. Cerebral edema is one thing that we have discussed. So if you are given aggressive fluid administration, that is one reason the patient can have cerebral edema. And there is a retrospective evidence that use of bicarbonate also has increased cerebral edema rates. So because the cerebral edema is common in children who have a very severe acidosis, in a very severe acidosis pH less than 7.7 or 6.9, usually there are some guidelines which support use of bicarbonate. Personally, if you ask me, I don't usually use bicarbonate. I use more of a fluid therapy in correcting the metabolic acidosis rather than bicarbonate, because by using bicarbonate has other downside effects that we will discuss. So now, what is the misinterpretations that you commonly see in ICU? Or if for that matter in ICU or in HDU, or if you receive a patient who has partially treated at outside hospital. So you do a VBG at your place, and then you see the bicarbonate is not less than 15. So you assume that this fellow is not in DKA. Because once you have a hyperchloremia, so there is a preferential absorption of, when you give, as we discussed, 0.9 NS is a drug of choice or fluid of choice. When you give chloride, there is a preferential absorption of chloride compared to the bicarbonate. So the bicarbonate is usually lost into the urine. So you partially think that the acidosis have resolved. So hyperchloremia would also cause renal vasoconstriction and oliguria, which has again deleterious effect on causing your fluid therapy in other spectrum, like causing a fluid overload because your kidney has gone into pre-renal AKA. So, and again, do not rely, as we already discussed this, so do not rely on urinary ketones, either for the diagnosis or for the resolution. The resolution should be based on the blood ketones, not urine ketones, because the urine ketones will be negative initially. Urine ketones continues to be positive despite your resolution of DKA. So now coming to the next entity is euglycemic DKA. This is very common these days because, as I already told you, so we all very much know that India is a global, almost has a global burden of diabetes is more in, India has a global burden of diabetes. So most of them will be on SGLT2 inhibitors. As we already spoke to you, I mean, as I already elaborated, this has a renal and cardioprotective. So most of the patients will be on these drugs. So they will have euglycemic DKA. So the treatment is same as normal DKA that we have discussed, and insulin rates should be the same. Because it's a euglycemic DKA, majority of them doesn't consider, because if the patient is clinically stable, I've seen certain clinicians thinking that patient is able to eat and he has a good sugar, why don't we treat him in the ward? That's what they say. So, but there are other modalities also I will discuss, but so if euglycemia, you're talking about euglycemic DKA, so you'll have to supplement 10% dextrose and decrease insulin infusion if you require to prevent hypoglycemia. The whole point is you're addressing the ketosis. So euglycemia is commonly seen because these days education is available everywhere. People can see it on the internet. There are some doctors who are giving very good counseling. And then there are other community programs where they're educating how to administer insulin and how to monitor what are the diabetic care that you have to take. So as soon as the patient recognizes that he is going to DKA, if he has priorly had DKA, he would definitely identify the next time he's having DKA. So he get partially treated at home. He'll drink some water or he'll get some fluid somewhere outside. And by the time he comes to you, so you may not have a classical picture of DKA, the pH-less, the triad that we have discussed. So the patients who are on SGLT2 inhibitors also will have ketones positive. So these patients also, this is one of the drug which can induce DKA. So now coming to the special population who is having DKA. So DKA in pregnancy. So DKA in pregnancy is very much common in second and third trimester. So although this is also like more of a euglycemic DKA only, and then, there is a decreased buffering capacity. As we all know, physiological changes of the pregnancy are your diaphragm goes up. So you will have a respiratory alkalosis. So you'll have chronic hypocapnia. What is a counter-regulatory, or what is your compensatory mechanism for your hypocapnia? You will also lose bicarb through your body, right? That is a compensatory mechanism that chronic hypocapnia would cause. So your bicarbonate is normally lost much during a pregnancy. So normally you can't rely on ketones in pregnancy because pregnancy-induced vomitings could be there. They could be not. They'll be hesitant to take food or water. So in that case, there would be starvation. So starvation can also cause ketosis. So the ketone bodies are not important in this. The ketogenesis is the pathogenesis, but knowing the ketone bodies, positive or negative, doesn't make major difference in treatment, because ketone bodies are invariably positive in pregnant ladies for obvious reasons, as I've elaborated. So you should always look at the glycosilic symptoms like polyuria, polydipsia, and is there a more increased respiratory rate? And when you do a VBG, you see an acidosis or not. So ketones are not very much into this triad of DKA. This is an exception. Now, so early recognition and importance are important for maternal and fetal, to prevent maternal fetal mortality, and multidisciplinary team has to be involved, that we all know. And pregnancy per se itself is a diabetogenic state. So what are the factors that can increase diabetic pregnancy DKA? So that is, one is insulin resistance, emesis and period of starvation, and concomitant loss of bicarbonate as a consequence of respiratory alkalosis, which happens as a physiological thing in pregnancy. So coming to the other special population, CKD, child. So basically in child, we have already discussed this treatment is remaining the same, but the rate which you give fluid should be slower. If it also determine if my patient is in shock or not in shock. If my patient is in shock, I give aggressive fluids till my shock is recovered, or till my shock parameters have come towards the baseline, and then we give additional fluid, and we correct fluids in pediatrics over 48 hours. So you have to calculate your deficits for 48 hours, and calculate it for 48 hours and give it as a hourly infusion. So this is how you classify deficits. Would be percentage of dehydration into weight in kgs into 10. This is how you calculate your deficit. This deficit should be calculated for 48 hours. And this maintenance fluid does not involve the boluses that you are giving in a DKA patient when they come to you. So if you call mild DKA, the pH is less than 7.3, you'll have a dehydration of 5% and bicarb of less than 15%. Moderate DKA 7.2 and dehydration would be 7% and bicarb is 10%, less than 10. Severe DKA, you have pH of less than 7.1, dehydration would be there more than 10%, and bicarb is less than 5. So this is what the flow chart of what I have explained. So my patient have a shock or not, that is the primary determination when you're considering DKA in children. Then what is the additional parameter? As we already discussed, the action 5, you have already established what should I monitor when I'm giving a treatment. So in addition, what should you do in a children? So in children, in addition, you have to closely monitor neurological status, as we already discussed. So rapid or over rapid correction of the fluid, or the, as we all know, the glucose will add to your osmolality. When you're high osmolality and you're rapidly correcting your osmolality of your blood, then there is a high chance of cerebral edema. So you have to look for headache, irritation, decreased consciousness, and then treat the patient accordingly. Stop the further fluid administration and treat patient with mannitol or 3% saline if you really suspect that it is because of the fluid administration and DKA management. If not, check sugars also. If it is because of the sugars, just simply correct the sugars. So this is what we're talking about. Yeah. Now, coming to DKA and CKD patients. So basically, we all know, unless there is a extracellular fluid loss like vomiting or loose stools or profuse sweatings, or because the tachypnea itself will cause a lot of fluid loss. Almost tachypnea will cause perforation losses of almost 1 to 1.5 liter. So unless you have some extracellular fluid loss, you're not supposed to give any extra fluid. The mainstay of treatment in CKD patients with DKA is only insulin. Insulin is the only treatment, unless you have extracellular fluid loss. If you have extracellular fluid loss, keep giving 250 ml of boluses and keep carefully monitoring. Look for the fluid overload signs, and cardiovascular monitoring should be there. Okay, so when do you dialyze these patients? Do we really dialyze the DKA patients? Because if you're just removing the acid, there is no point. So you have to address ketogenesis. The ketogenesis can only be addressed by insulin, which cannot be addressed by any other thing. So despite insulin, adequate insulin, or a patient is in severe pulmonary edema, hyperkalemia, and patient is a CKD, you will dialyze these patients. And coming to our DKA triad, what we have discussed. So we have anion gap more than 16 if you're including a potassium. So now, normally the CKD patients will have organic anions build up in their body. So obviously they're going to have high anion gap. So, but if the anion gap is more than 20, then that should be considered as a significant, and it will always point out towards DKA. Normally, a CKD patients will have organic anions, but the anion gap will not be more than 20. If anion gap is more than 20, then you should always carefully consider it. The important electrolytes that is very much deficient in DKA is phosphate. So hypophosphatemia is one of the complications which is very much neglected, and patients will have a severe muscle aches and severe cramps. So you should always correct phosphate. But before correcting phosphate, please make sure that you check the hypokalemia or hypocalcemia, which is very much common in CKD patients. So now coming to our differential diagnosis of DKA, we'll have HHS, we know hyperosmolar state, then starvation ketoacidosis, alcohol ketoacidosis, acute GE with severe dehydration is one that we are considering. So the questions which I struggled or I have learned myself over these years with and which whenever I manage DKA patients, these were the questions which were coming into my mind and my colleagues' mind over these years. So the role of ketones that we already discussed, the role of urine ketones is very much minimal. So do not use urine ketones for diagnosis or for resolution. Role of bicarbonate is very much limited when pH is less than 7 or 6.9. You use bicarbonate because it paradoxically it paradoxically causes more acidosis. It also causes serious it increases the CO2 in the brain and causes stimulates the respiratory drive and causes tachypnea or respiratory distress. So other electrolytes which are abnormal, which we have discussed in detail. The point I wanted to make here is there is a SPIT protocol which is commonly done for mild and moderate DKA. It is not for the severe DKA management. If patient is having mild and moderate DKA, there is something called SPIT protocol. This is a randomized control study. So which showed that if the patient is having mild to moderate DKA, you can give subcutaneous insulin and you can monitor this patient in ward. Okay, what is the dose that you give? 0.2 units per kg, and you give it every 2 hours and check the sugars and then treat the patient according to this. But at the end of the day one, if your DKA target parameters are not being achieved, then you will have to shift to IV form. And then, not to forget, we are all liable persons and we are all in a critical juncture whenever you treat a patient. So documentation and quality assurance is one thing which should never be forgotten. Never events, of the never events are dangerous or inappropriate use of concentrated electrolytes. And please clearly write the drug orders properly and the targets that we have written. So for instance, I will write as give 0.1 unit per kg per hour. His ideal body weight is 70 kgs. I will write 7 units per hour should be given. And then carefully monitor the potassium and ECG monitoring should be there. And then hourly glucose monitoring should be there. This is everything should be documented on a piece of paper. Then the discharge advice is one thing which is very much important. As we already discussed, one of the most common causes insufficient insulin. So patient skips their insulin. So you should educate them on what to do, on how to titrate their insulin therapy. And not to forget, prevention is one of the very much important thing in DKA. So the proper education by the healthcare professionals should be given, and sick day management. When patient is ill, how should they use glucose, and how should they titrate, because they don't eat much. People usually think that when I'm not eating, I don't want to titrate my glucose insulin. It doesn't work that way. So because your insulin is mobilized from the other sources, although you don't take it, there'll happen a glycogenolysis and gluconeogenesis. So the glucose is mobilized from other sources. So that glucose has to be addressed. So, and then this is what, and the caregivers are also a part of your patient management. The caregivers also should be explained when to give insulin, when not to give insulin, when to not discontinue the insulin. And the last slide, coming to the scenario, I would like to give one scenario. You have received a patient of 21-year-old type 1 diabetes, able to eat orally, skipped his insulin, nausea intermittently, noticed low-grade temperature. ER observations are heart rate more than 110, sinus rhythm, BP 130/80, heart rate 19, so respiratory rate 19, GRBS is 184. But my VBG is showing severe metabolic acidosis or metabolic acidosis with high anion gap. So now in this patient, I would like to do a blood ketones if it is available, or else I'll do urine ketones, but urine is not going to determine my diagnosis. Here I'm very much clear. My patient is having high iron gap metabolic acidosis. He is diabetic. That itself will confirm my diagnosis. So how do I treat this patient? This patient should be treated like every other patient, because he is having acidosis. Is classically falling into the criteria. I start fluids based on his fluid volume status of his body, and then insulin infusion should be started, and then parallelly you should give 10% dextrose and treat this patient. So never ever ignore if your patient sugars are less, but the other criteria is satisfying. You don't have to have a classic triad in all the patients. There you should have to use your clinical acumen. So these are my references. Any questions I can take up?
Dr. Prasad, thank you so much. That was very informative and extensive presentation. I think after listening to your topic, because the topic is very conceptual, precise, and I think all the points are covered. So hopefully after listening to your topic, I hope, I bet and hope that participants will not have any questions. I'll see. There are no questions in the chat box. I think as your concept is very clear, so there are no questions.
Okay, if you wish to have any questions, you can always reach out to me on Dr. ldvprasad30@gmail.com. So I will be happy to help you. Thank you.
There's a question.
Yeah.
Can we see the protocol of management in flowchart?
Which protocol?
I think the DKA protocol they're asking about. Management of DKA.
Yeah, I don't have a flow chart because it is all, see, since this is tailored to each patient, we can't follow a particular algorithm. Okay, so it is that key first choice is fluid, that is what you do, and then insulin is what is a protocol. There is no fixed algorithm like ACLS or something, because it is completely tailored to the volume statuses and the clinical scenario of the context of the patient. That's all. I don't have a flow chart of it, but this is essentially what you have to do. Start fluid, give insulin, and this is what these 3 slides are essentially the answer for your question.
I think it's clear. There are no more questions.
Yeah.
Okay, let's end the topic. And thank you once again, Dr. Prasad, for such an informative talk.
Thank you. Thank you, Srinath.
Have a nice day.
Have a nice day. Thank you.